Today's topic is pins and needles of neuropathic pain. The objectives of today's webinar are: have the awareness of the physical and functional burden of neuropathic pain, have the ability to properly diagnose neuropathic pain, be updated on the treatment guidelines for neuropathic pain, and have the clinical eye in assessing the efficacy of treatment of neuropathic pain. Today's speaker is Dr. Reynold Peter Ramiro. Dr. Ramiro is a graduate of the UP College of Medicine, where he also did residency training in physical and rehabilitation medicine. He is a diplomate and fellow of the Philippine Board of Rehabilitation Medicine and a master's candidate of teaching medical-related subjects. Dr. Ramiro is of the College of Rehabilitative Sciences of the Cebu Doctors University. He is also an assistant professor in the College of Medicine at CBU. Dr. Ramiro is also head physiatrist and electromyographer at the Cebu Doctors University Hospital and the Macnan Doctors Hospital. He is the immediate past president of the Philippine Academy of Rehabilitation Medicine. Let us all welcome Dr. Ramiro.
Hello everyone, thank you Melissa. So our topic for today is on the pins and needles of neuropathic pain. And you know, pain is now considered as the fifth vital sign. And anything with pain, which is an unpleasant sensory and emotional experience associated with actual or potential damage, is something that our patients complain about. You know that pain is common, and there are different types of pain, and treatment depends on the type and classification of their pain. Of all the symptoms of neuropathy, is actually the pain that brings them to see us. Our topic is on neuropathic pain, and we need to differentiate it from nociceptive pain. So any pain dealing with a lesion to the nerve or any dysfunction of the nerve would cause such. So neuropathic pain is defined as pain that arises as a direct consequence of a lesion or disease affecting the somatosensory system. It could either be peripheral or central. And as mentioned earlier, our learning objectives for this session would be to have the awareness of the physical and functional burden of neuropathic pain, to have the ability to properly diagnose neuropathic pain, to be updated on the treatment guidelines for neuropathic pain, as well as have the clinical eye in assessing the efficacy of our treatment. So awareness of the physical and functional burden of neuropathic pain. So it is estimated as high as about 7 to 8% of the general population in Europe would have neuropathic pain. And in some other studies, they noted that this could be actually about 6 to 8% of the general population. Now, painful diabetic neuropathy is estimated to affect between 16 and 26% of people with diabetes. And the prevalence for post-herpetic neuralgia would range from 8 to 19%, wherein severe pain could be seen with this condition, and at 3 months would be at 8%. The development of chronic pain after surgery is also fairly common, and the estimates for this would be 10 to 50%. And severe kind of neuropathic pain would be seen in about 1/5 of such cases. I am bringing back this slide wherein low back pain may just be nociceptive pain, but when it becomes chronic, there would already be a neuropathic pain component, such that treatment would now be a bit different. Now, neuropathic pain is associated with psychological distress, physical disability, and reduced overall quality of life. And a lot of the complaints that patient would tell us would be like difficulty in sleeping, lack of energy, drowsiness, and difficulty in concentrating. And all these things would affect their ability in their work or in their function, like if they're a student, they're working in a factory, or they're in a corporation. So all of these would affect ability, and medical expenses also contribute to the overall cost of neuropathic pain. Now, how to properly diagnose neuropathic pain? So I have here a grading system to be able to determine whether there is definite, probable, or possible neuropathic pain. So this is from the American Academy of Neurology. Basically, there are four things to look at. Pain with a distinct neuroanatomically plausible distribution. That's one. Number two, a history suggestive of a relevant lesion or disease affecting the peripheral or central somatosensory system. So these first two are important, and if they are present, then we call it possible neuropathic pain. Now, if we have a third, which is demonstration of the distinct neuroanatomically plausible distribution by at least one confirmatory test, and one of these tests that we do in the physical and rehab med specialty is electrodiagnosis. So like if there is neck or cervical radiculopathy or back pain with radiculopathy or what we call lumbosacral radiculopathy, this can be confirmed by this procedure. And the fourth one is demonstration of the relevant lesion or disease by at least one confirmatory test. So if both 1 and 2 are present with plus either 3 or 4, then we consider it probable. And if all 4 are present, then it's a definite neuropathic pain condition. And the significant signs and symptoms that we would be looking for are the following, like spontaneous pain, persistent burning, intermittent shock-like lancinating, or dysesthesia, which is abnormal, unpleasant sensation, paresthesia, or abnormal, not unpleasant sensation, and numbness, which is a negative sign of reduced sensation. It could also be stimulus evoked, like allodynia, wherein stroking or warm stimulus, which are not really painful, are perceived as painful, or hyperalgesia, a heightened response to a painful stimulus like a pinprick or to cold, and hyperpathia, delayed explosive response to any painful stimulus. So this is how we do it with pain. We have to check whether pain distribution neuroanatomically plausible and history suggesting a relevant lesion or disease, both are present. Then we say, if not, then probably not neuropathic pain, but if yes, then we have a working hypothesis of a possible neuropathic pain. Then we need confirmatory tests. Both are present, then definite. If only one of either a negative or positive sensory signs confined to innervation territory of the lesion nervous system structure, or a diagnostic test confirming the lesion, then probable. And if neither are present, then it's just an unconfirmed neuropathic pain, possible neuropathic pain. Now we go to our third objective, which is the treatment guidelines for neuropathic pain. So pharmacologic treatment is actually the recommended first-line treatment for neuropathic pain, and a lot of the medications that are currently being used are actually anticonvulsants. And several of the mechanisms of action that would result in relief of neuropathic pain include blocking the peripheral sensitization by blocking the sodium channels, blocking central sensitization, restoring inhibitory controls, as well as binding to alpha-2 delta-1 subunit of the calcium channels. And initiating symptom treatment with one or more of the following will include our anticonvulsants, making use of the calcium channels like your gabapentin or pregabalin. Then we also have antidepressants like your secondary tricyclics, like your nortriptyline, desipramine, or your serotonin, norepinephrine reuptake inhibitors like your duloxetine, venlafaxine. So the antidepressants may be used for those with neuropathic pain as well as depression present in the patient. And for those that may not really respond to the first two, especially for those with acute pain, cancer pain, and episodic exacerbations of severe pain, then our opioid analgesics and such as tramadol may be used in combination with the first-line therapies. So two examples of such wherein neuropathic pain is very much evident would be painful diabetic neuropathy. As I mentioned earlier, present in almost 25% of the patients, and post-herpetic neuralgia. So how do you choose agents based on these two underlying conditions? Well, we have here, again from the American Academy of Neurology, some evidence-based guidelines in the treatment of painful diabetic neuropathy. For level A recommendation, we have pregabalin to around 300 to 600 milligrams per day. And level B recommendation would include your gabapentin, your venlafaxine, your duloxetine, your tricyclic amitriptyline, and like your opioid, like your tramadol would also be included. What we use at the physical and rehab med, like your electrical stimulation, percutaneous nerve stimulation would also be included as level B, but has to be done 3 to 4 weeks. For post-herpetic neuralgia, those with medium to high efficacy with good strength of evidence and low level of side effects would include our gabapentin, our pregabalin, our tricyclic antidepressants, even oxycodone or morphine sulfate for severe pain, and a lidocaine patch. Now, from the European Federation of Neurological Societies, they have guidelines as well, like for diabetic polyneuropathy. Similar medications that I mentioned are also listed here, and such as your gabapentin, pregabalin, your duloxetine, tricyclics. So these medications, which you will be hearing again in the next succeeding slides, are mainly the first line of treatment that we use for neuropathic pain. For post-herpetic neuralgia, you have gabapentin again and pregabalin and some of your opioids. For trigeminal, this is where carbamazepine still has a big role. So that is still the first line of drug, an anticonvulsant for trigeminal neuralgia. For central pain, which could either be due to spinal cord injury or some other conditions, we have gabapentin, pregabalin, and your tricyclics. For cancer pain, gabapentin has been noted to be the drug of choice. Here, a summary of the results of RCTs for first-line medications for neuropathic pain. This is for central pain. So what is the role of your antidepressants and your calcium channel ligands, gabapentin and pregabalin? So for post-stroke pain, they considered the TCA as having an effect, as well as pregabalin. For spinal cord injury, we have the gabapentin and pregabalin as the ones having an effect and not on your TCA. And our fourth objective, having a clinical eye in assessing the efficacy of treatment of neuropathic pain. So the main thing here is really to reassess the pain once the patient follows up, and also ask whether there is also improvement in some health-related conditions, like in their sleep, in their fatigue level. So these are very important. And how to evaluate if treatment given is effective is, of course, allowing the medications. These are not fast acting, so we have to allow them to take effect to our patients, probably at least 2 weeks, and then let them see us again. We have to inform them about the minor side effects that may happen, like drowsiness, which in a matter of days they would be able to tolerate. So what we consider a substantial pain relief is to have an average pain reduction to 3 or less out of 10. So that would be more than 70% pain reduction. And if such happens with tolerable side effects, then we may continue the treatment to be able to get more reduction in their neuropathic pain. Now, when they come back and they just have partial pain relief, which means average pain remains 4 or greater out of 10, which is about 60 to 30% of pain reduction, then an adequate trial that we did, we may need to increase the dose of what we have given, or probably even add another medication to the treatment. If there is no or inadequate pain relief, we're in less than 30% reduction of the initial pain level of our patient, then what is needed is probably to switch to an alternative first-line medication. So the other medications that we have discussed earlier, so those have to be tried. Now again, our medications for neuropathic do not affect instantly or within a day or two. So the patient would have to know that they have to be patient enough to be able to get the relief that we want for our patients. If trials of first-line medications alone and in combination fail, then consider other medications like your opioids. Now, from a Cochrane review, actually no recommendation of any one specific drug combination was seen for neuropathic pain, and apparent adverse impact of combining agents with similar adverse effect profiles like depression would have to be watched out for. From the Canadian Pain Society, they mentioned that available studies do not support a recommendation of any one specific drug combination for neuropathic pain, although studies do provide a rationale for combination pharmacotherapy. Again, we have to base it on the risk of the patient to monotherapy and see whether we get the desired improvement based on patient follow-up. So this is just a summary of the treatment guidelines from the American Academy of Neurology, from the European Federation of Neurology, from the National Institute for Health and Care Excellence from the United Kingdom, and from the Canadian Pain Society. So first line for diabetic painful neuropathy, we have pregabalin for the 4 societies. Then we also have gabapentin, duloxetine, and amitriptyline. For post-herpetic neuralgia, it's gabapentin for all 4. Then we also have pregabalin, your duloxetine, and amitriptyline. For other painful neuropathies, non-diabetic related, we have gabapentin and pregabalin with duloxetine and amitriptyline. For trigeminal neuralgia, please take note, it's still carbamazepine as the drug of choice. For cancer pain, studies show it's really gabapentin who has a role for this. And for spinal cord pain, both gabapentin and pregabalin, as well as your tricyclic antidepressant. So further studies may be useful to determine the effective combination of these medications that we mentioned. And for fibromyalgia, which has a neuropathic component, as we all know, it's pregabalin, that has studies for this, as well as your tricyclics. And for post-stroke central pain, wherein they suggest more pregabalin for the American Academy, for the European, with gabapentin or your tricyclics. So in summary, we just want to emphasize the following: the neuropathic pain prevalence of 6 to 8% in the general population, and this would cause both physical and functional burden in our patients. Utilize the grading system 1 to 4 in diagnosing whether we have a definite, probable, or possible neuropathic pain. Pharmacotherapy is a recommended first-line treatment for neuropathic pain. And finally, we need to regularly assess our patients to determine the efficacy of our treatment of neuropathic pain. Thank you for your attention.
Thank you, Dr. Ramiro, for that very practical and clear discussion of how to diagnose and manage the different types of neuropathic pain conditions. We would also like to thank today's sponsor, Medicam, and our media partners, the Philippine Daily Inquirer and the Filipino Doctor. Before we proceed to our Q&A portion, may I introduce our reactor for today's session, Dr. Maria Teresa Cañete. Dr. Cañete graduated from the UP College of Medicine. She did her residency in internal medicine at the New York Medical College and her residency in neurology and fellowship in stroke at the Albert Einstein College of Medicine. She obtained her graduate diploma on clinical epidemiology at the University of Newcastle in Australia. At present, among her numerous positions and academic appointments, Dr. Cañete is lecturer at SWU Medical School and Cebu Doctors University. She is also an associate professor at Cebu Doctors University and an active staff and staff neurosonologist in the same institution. Let us welcome Dr. Cañete.
Hi, good afternoon. Parkinson's disease, brain tumors, limb amputations, brain injuries, and spinal cord injuries. And it may take years or months after the injury to develop. So this is the central pain modulation diagram, and we see here the structures that is important for modulation. So somewhere in this spinal cord or even in the brain and up all the way to the cortex, if there is a lesion somewhere and you have sensitization of your central nervous system, then you will get that central pain syndrome. And how is treatment different with your peripheral nervous system? Well, clinically, it's a bit more difficult to treat because it's you can say more resistant to the usual drugs. But of course, there are already newer studies that show that the same agents might work. For example, they have shown that antidepressants like amitriptyline, and there is a local company that makes this or that imports this as a generic, amitriptyline can be tried for central pain. And again, this from the same slide, Dr. Ramiro, we can, for central pain syndrome, it's still trying antidepressants, your alpha-2 deltas, which is gabapentin, pregabalin, and your other second-line agents would be duloxetine, vaccine. You can use topical lidocaine, especially for your herpetic neuralgia, especially if there is already sensitization. And third-line agents with opioids. Now, I thought of looking at anti-epileptic drug latest, unfortunately, the Cochrane says there is only the use of gabapentin and gabaline which has good evidence. The rest, not so good yet. And from the clinical practice that still some good results in gabapentin and pregabalin. So what happens is a patient develops after in the clinics that the stroke area, the plegic side, that patient gets. You can try her first on pregabalin, come back and see if it works, and then if it doesn't, you can add. You can try different. Also, still individual. Now, instead of showing this to you, I grabbed this from the. There's a difference between pregabalin and gabapentin, especially with regards to time to effectiveness. Bottom side of the slide, you can see that it's 1 day for pregabalin to take an effect. And so the first thing that the patient feel a bit dizzy. While gabapentin, so you slowly up the gabapentin. So 100, 3 times a day, etc. And tell them to hold on. Don't just say it doesn't work. You keep trying, you let them stay on the drug, and then go to effective dose usually, and then let them come back and tell you what on them. So let them this drug first before saying it. Okay, that's it.
Hi, thank you. Thank you, Dr. Cañete. Hi, can you hear me? Inside? Thank you for your insights. It's nice that we were able to review the neuroanatomy, give us a little bit of review of the neuroanatomy and how it produces neuropathic pain, and discussion on the central pain syndrome, which is, of course, different from the peripheral neuropathic pain syndrome. I appreciate that very much. So we can now proceed to the Q&A. We're checking for questions. Okay. We have some questions from our participants. First question is, are all medications to be given round the clock or as needed, only if pain is intolerable or uncomfortable? You want to answer that, Dr. Ramiro?
Okay, thank you, Meling. Definitely the treatment for neuropathic pain is different from those of nociceptive pain. In neuropathic pain, they have to be taking the medications religiously because it has to be taken for long periods in order for the effect to take place. Unlike for our usual analgesics, wherein probably we would just recommend about 7 to 10 days for severe pain, then probably they could stop if the pain is gone. But for neuropathic pain, it has to be continued. As I mentioned, it is being monitored ideally every 2 weeks. And we have patients who are taking it chronically for several months.
Have you had any problems with patients taking it for a long, long time, like months?
Not much in the for chronic intake. It's in the first 2 weeks, wherein the complaints of the dizziness would be the main reason why they would come back and probably even ask if we could change the medication. But for chronic intake, it doesn't have the crucial side effects that the common NSAIDs that we have would have in our patients.
Thanks, Dr. Ramiro. Is there any evidence for alternative medicine for neuropathic pain? This question comes from one of the participants. Any anecdotal experience?
Well, as mentioned in one of my slides, so one of the modalities that we use in physical therapy would be the cutaneous electrical nerve stimulation, which has level B evidence. Again, as I emphasized in this lecture, is really the medications, the pharmacotherapy, which is the first line medication for neuropathic pain. Now, there are some supplements that are being marketed to also relieve neuropathic pain, like, for example, the pure vitamin B12, mecobalamin, and an amino acid uridine, which they are being used to also lessen the symptoms of neuropathic pain. And probably Dr. Cañete would have some inputs on this.
I might have inputs. I'm going to share you a few slides on vitamin supplements, I think, or other supplements. There's not much evidence for the uridine monophosphate. There are very small, they're actually open label. Everyone is on the uridine monophosphate. So I don't think it's really gold standard. So I'll show you these slides that I have. Now, you can look at this article on lessons from the history of randomized clinical trials, how to really prove that something works. And it also says that shows us that
excuse me, can you
it's
share
a very
the
big
screen
thing.
so that we can,
Also,
we can see the slide?
Another slide shows here the placebo effects of medicine. So there is very of the drug, you can say could be right. You could say when you talk to a patient about a drug that it work, that advice that you giving therapeutic effect on the patient. So as the Dr. Ted perspective, journal placebo effects of medicine, he says placebo effects can help enhance the effectiveness, like in patients with migraine, asthma, irritable bowel syndrome. The clinicians themselves create a placebo effect through empathy and support. So you better hone up on your bedside, because you will save the patient if you know how to and give them assurance that your medicine works. So there is that placebo effect.
Like it
Don't necessarily, but they relieve.
Yeah, I guess just like
In medical situation, if cure is available, preventive healthcare can be better. And this placebo effect, and there, so it's have a good doctor relationship.
Yeah, Thank you, Dr. Cañete.
When patients
Yeah.
are immersed in their emotional circumstances.
That's right. There's another question here that came in, and they're asking, how do you treat pain caused by quinolones?
Would you want to answer that, Melissa?
No. Excited to hear that. There's a question here about
Pain with
pain
quinolone.
being caused by quinolones. Have you had any experience with that, like drug-related neuropathic pain? Because sometimes, like cancer, when you're treated
I don't
with chemotherapy drugs, when they cause neuropathic pain.
Probably if it's more of nociceptive, then we would, of course, have our anti-pain armamentarium. I'm just not sure about whether it could also cause neuropathic pain, but again, it really depends on the presentation of the patient. If it's if there is neuropathic component, then the role of the medications that we discussed would be there. But if it's really more of a nociceptive, like probably problem with the joints or tendons, then we give more medications for nociceptive pain.
But those drug-related or drug-induced neuropathic pain conditions, just
I
like
think
in
if it's
your
chemotherapy,
slide earlier.
like peripheral neuropathy.
Right.
Yes. You can still use the normal agent. Yes.
Yeah. It shows that
Yes,
gabapentin was the drug of choice for chemotherapy.
For cancer
Yeah.
pain, yeah, it's gabapentin. You are right, Melissa.
Okay, the other question here, if after several months neuropathic pain resolves, how do you discontinue the medications? Example, for pregabalin, do you abruptly discontinue it, or you have to taper it?
And then any medications that are taken chronically, then it will be best to taper it. Like if a patient has been receiving like to very high levels of up to 600 milligrams per day, then probably in a week or so it would gradually lessen the dose. And hopefully the effect of these medication in terms of relief of the neuropathic pain would be still present in our patient. And probably after a month, we could ask them to see us again.
Same with you, Dr. Cañete? Do you actually taper off the medications, or you just discontinue it?
Yeah, I think it's very important. Yeah, it's very important to. I would have to advise. I would have to advise slow taper. There is in the internet somewhere reports of a withdrawal syndrome from, I think, so you have to taper slowly. Tell the patient, don't just stop it, no, and over a few days at least. They feel a withdrawal. They feel weird. They don't if it's the medicine which they stopped. So please taper slow.
Okay, thanks, Kinsai. There's another question here. The opioid epidemic has been a challenging issue. What would you recommend to check for and prevent addiction? Is it actually an issue for pregabalin and gabapentin?
That's an interesting question, Alvin. Yes, we have to, especially we need to use our opioids. Addiction is always something that we need to prevent and control. In the Philippine setting, I'm not that, I mean, the prevalence of the use of the opioids, for me, well, in my set of patients, is not seen. I don't know, of course, in the US, I see a lot of the expats here that are given the opioids as for pain. I know there is a tendency for it, and we have to be very careful if ever we do start them on opioids. Inside.
Inside, do you want to comment on that as well? About addiction? Okay. Next question is,
Tina.
can we combine gabapentin and pregabalin with antidepressant medications? Example, duloxetine for pain control.
Oh, hello, Dong. Yes, yes, we can. Actually, if the monotherapy, whether pregabalin or gabapentin, does not work, then we can combine with other medications like your antidepressants, particularly your duloxetine. But again, studies or evidence really do not show any particular combination, but those can be tried. Again, you have to monitor the patients, get their response, and see whether we do get good results.
That's right. The main thing is we really need to monitor for the response of the patient.
Yes, Melissa.
Right? So they should really follow up so we know how to manage them really well. So as mentioned in the lecture, pain relief is subjective, but there are instruments that one can use to be more objective. As such, what pain relief assessment scoring aside from the pain scale do you recommend or frequently use and practice?
Well, in my practice, it's really the visual analog scale that is used. There's an aldometer, but it's really probably more for nociceptive kind of thing. Tinsai may probably want to mention some others.
Yeah. Tinsai, do you use any other pain scale or any other assessment for relief?
I think the basic assessment score that I use is still the visual analog scale. And then, of course, it's the subjective relief of the patient plus the things that now she or he can do, or he can walk a bit longer. You may do other scales like a walking scale, but I only use the visual analog scale, the pain scale.
Right. You want to add anything?
No, it's okay. Yeah.
Okay. Yeah. The next question is Dr. Ramiro mentioned about international guidelines. How about local guidelines? Are there any local guidelines?
Probably from the local neurology group. Tinsai, would you have?
Any about neuropathic pain?
I'm not aware of local guidelines, but that's okay because I think what works for them also works for us. It's nice that the medications that we used in the US can be available here. I've seen the same kind of response. Maybe we need to work more in the Philippine Neurological Association to give local guidelines. For now, in terms of the topic of pain, I think international guidance work too. I don't know that we necessarily have different response to the medicines that have been developed internationally in the US. So no, we don't have yet local guidelines.
Well, I'd like to thank Agot for that question. Probably the pharmaceutical industry may also probably come up with something to have a local guideline, if not, or the Philippine Society of Neurorehabilitation.
Right.
Yeah.
There's an interesting question here from Tina. What do you think of using medical marijuana for neuropathic pain?
Hello, Tina. Yes, yeah, based on, it's more on central pain, based on the evidence, and more on multiple sclerosis, based on what we have here in the report.
Cancer pain responses? No, just central pain.
Yeah, for central pain. But again, it's not yet approved here, right, Melissa?
I don't think it is.
Or if it will ever be.
Okay. That's the last of the questions.
Any more questions from the international audience?
Okay, that was quite an engaging discussion, Dr. Ramiro and Dr. Cañete. Thank you very much. And to summarize, we learned that neuropathic pain prevalence is 6 to 8%, and it really gives us a physical and functional burden. Now, Dr. Ramiro also discussed a clear algorithm depending on patient response, and this really just highlights how important it is that we be able to reassess the patient and in terms of their response to the treatment that's given.
Yeah, nothing to do.
So quite an interesting topic, pins and needles.
Yes, pins and needles.
So for the
Thank you for the title, Melissa.
You're welcome. For the information of our participants, after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thank you for joining us. Please join a special webinar by Class 1990 on research tomorrow, September 8th, Wednesday, 9 a.m. Manila time, with speaker Dr. Leo Selly on the topic of perils of observational research. This is really an initiative by Class 1990, the class before us, Silver Jubilarians of last year.
Mm-hmm.
We hope to see you again in our upcoming webinar, 28th as well, Wednesday, 12 noon to 1 p.m. Manila time, with speaker Dr. Gary Lorenzo, who will talk about novel therapies for lung cancer. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at our Facebook page, UP Med Webinars. You may also subscribe to our mailing list at http://upmweb-mailing list-2016. You may also email us at upmedwebinars2016@gmail.com for any inquiries. On behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, the UP Manila Information Management Service, National Telehealth Center, UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, EOST, ASTI, and our host, Ms. Charisse Arhalo of UP Telehealth. Once again, we would like to thank our sponsor, Medicam, and our main media partners, the Philippine Daily Inquirer and the Filipino Doctor, for their support. This is Dr. Melissa Mercado, together with Dr. Reynold Ramiro, Dr. Teresa Cañete, and the UP Med webinar team, closing this session. We hope you have learned a lot from today's webinar. Join us again tomorrow, September 8th, for Class 1990's webinar, and on September 28th for our webinar on lung cancer. Have a great week ahead.